That's in your books. Trauma to the head, neck, and spine. Now remember, this doesn't replace you actually reading your book, because there's a lot of information in there that is important, but this is just my general overview of the presentation that was supplied by them. So there are a couple things that you can read. That's going to, mainly the topics, and we'll break down as we go. Nervous in the skeletal system, injuries to the skull and the brain, wounds to the neck, and injuries to the spine. So starting with the nervous in the skeletal system, straight up the structure and the wiring. A little added thing that I put in for this one is if you see an ambulance emblem, like in the top left of this, in any part of this presentation, that's probably a good sign that you're going to see this again at some point. Whether pop quiz, regular quizzes, maybe I'll just ask you randomly in class. But you're going to see the information that's either on that slideshow or something I said during this part again. So your nervous system in general is the wiring. So remember, it controls your thoughts, sensations. When I say sensation, that means anything, pressure, heat, cold, anything inside your body, your sensory nerves, and your motor functions. Motor function is how you move. And so we start with the central nervous system. Remember, the brain and the spinal cord, y'all all should know that ahead of time. And then everything across from that, or outside of that, is the peripheral nervous system. That includes your vertebral nerves, the cranial nerves that come out of the head into the face, and then you've got the motor and sensory nerves. So anything that comes out on the peripheral nervous system comes out from between the vertebrae, and they have pairs that go all the way across. And that's easily labeled out in your book. It makes it a wonderful illustration of it. But your motor and sensory nerves are included in that because that's how your body sends messages back to the brain, is through your sensory nerves. So here's a breakdown of everything we just said. And anything that's in pink is your central nervous system. Think central because it's in the middle. And then anything off of that is your peripheral. So remember your side. And I would look at the definitions of those as well. There's your little ambulance. So starting at the head, cranium, you know what that is your skull. There's 14 separate facial bones in there. And then when you get to the mandible, remember your mandible is your lower jaw bone. And then you got the temporal bone that forms right in there in your mandibular joint. So if you ever heard of TMJ or it pops or anything, that's usually related to that. Then you got your maxilla, which is your upper jawbone. I remember that. And then you know your nasal bones and your zygomatic and your orbits. And you know what the spinal cord is? It's the cord that goes out of the brain, leaves the skull through the foramen magnum. So remember, that foramen magnum is the hole that's in the bottom of the skull that I've shown y'all before. And that's where that cord runs out. And then it runs through the vertebrae, because the vertebrae helps give it structure and also protects it. Now, the brain isn't just floating around or just like loose in there. It's surrounded by the CSF fluid, which is cerebral spinal fluid. And it also is all encapsulated in there. So there, all the way down through the spinal cord, everything floats in CSF fluid. So here's a breakdown of all the different bones of the skull, of the cranium. I'm not going to break down every single one of those, but especially when you're looking at the different parts of it, it's easy to say, hey, if I got hit in the back of the head, it's one in the occipital area, the temporal. Remember, you've heard of your temporal, right there on the side. So moving down, that's when we said we had the vertebrae. And if you really look at it, it's easy. As I've always remembered, it's 7, 12, 5, 5, 4. And when you're trying to remember exactly what's in each section. Now the next one is a better animation or illustration of it. So you've got your little ambulance at the top, but I would remember you got your cervical, which there is 7 cervical vertebrae, which if you look at it, how it's kind of hanging up out there, it's not really protected. So that's kind of what makes it more easily damaged, because there's nothing protecting it at all except for that one little structure, that one little column up there. But also that's where your brain stem comes out through, right there at the top. So everything from there down relies on the cervical spine being protected. So then you go down and you got your thoracic vertebrae, and there's 12 there. You can see that's where the ribs connect to in the back of the thoracic. And then you go down to the lumbar, which is your lower back. If you think of when you buy a chair, it's got lumbar support. That's what it's talking about. It supports your lumbar spine. And then below that, you have your sacrum and your coccyx. So moving on to the injuries to the skull and the brain. There's your little skull again. So scalp injuries is literally just the tissue that's over top of the scalp, or that's over the cranium, because we don't walk around with bare skull. There's a lot of tissue and hair and everything. Lots of blood vessels. When it says profuse bleeding, it's not kidding, because it's so vascular and it's kind of hard to, it can almost be distracting as people see all the amount of blood that's in hair and things like that, and they get so focused on it when literally after you clean it all up, it's really just a cut. But you really have to go through, there's so much blood that you have to comb through to see the actual underlying injury. And then when you get to the actual skull, which is the whole cranium, so when we were talking about like open fractures and closed fractures before, it was referring more to the skin. So that's how we were guiding whether, hey, is it open? It was the skin broken. So with a skull injury, it actually is referring to the actual structure, the cranial structure of it. So if it's an open head injury, it means that the skull itself is broken. If it's closed, it means there's a head injury, but the bones itself were not actually broken. So this is an open skull fracture. So when you look in there, yeah, he pulled the scalp and everything apart, but when you look in there, you can actually see where the actual skull is broken. So there's your little ambulance again. So you got your direct injuries, which means it's directly injured. Like whatever happened directly to the brain. So lacerated, punctured, bruised, broken bones, foreign objects. Like foreign just means it's not supposed to be there. It could be a screwdriver, gun, who knows. Indirect, which means, yes, it hit the head, but it didn't like go through and into the skull and directly affect the tissue itself. So when it's saying the shock of the impact on the skull is transferred to the brain and include concussions and contusions. And we'll go through with that in a second. So imagine like you grabbed something. Let's say you had an apple inside of a jar and you picked it up and slung it around in your hand real fast. The apple inside of the jar struck the inside of the jar, even though the jar didn't break or anything like that, but that movement is what hit, and it'll still bruise that apple. So mainly these are going to be anything that disrupts the normal functioning of the brain. So you got your concussions, which have different mild ratings, and it'll be explained better in the next one. But mild, usually there's nobody even knows there's an injury. Or you could have a contusion. The coupe contra coupe is just kind of like that apple that's still in that jar, and you shook it. And it caused damage not to the jar, but to the apple inside because of the force of it hitting. And that was an indirect injury. So when you start talking about your concussions are a big deal, especially like sports and things like that. But usually it's mild, but people may be knocked out for a second. There's not like any kind of lasting brain damage normally. But brief loss of consciousness, and may get knocked out, but they wake up. Headache, grogginess, might have some trouble remembering what happened, but you can see, just like that, it's the force of the brain striking the inside of the cranium. Now, your contusion, because we all know that contusions are bruising. It's a collection. But this is where there's actually bruised and there's an actual true kind of brain damage injury, and there's blood collection in the tissue. Now, these people will go unconscious, be severely altered, may wake up, lose consciousness again, but this is, remember, contusion is a bruise. And these are closed head injuries. So there are different types that can happen. Obviously, you've got your lacerations, which we know is like a cut, anything like that. Hematomas. So remember, a hematoma is a collection of blood in a closed space. So you got your subdural, epidural, and intracerebral. And in a second, we'll go through exactly what those mean. Because you'll hear a lot of that, like, oh, they had a brain bleed, and they rattle it off. So if they say, oh, they had a subdural bleed, okay. Well, because what it is that subdural is meaning that it's based on the location inside the body or inside the brain. If you look in your book on page 794, at the bottom they have more of an exploded thing. And it'll show you the different layers between the bone, the dura mater, the arachnoid, and the pia mater. In the different spaces, that's where it collects. So if I say, hey, he's got a subdural bleed, sub means below, and then you got the dura mater. So I know that it was below in levels. It's below the dura mater. So subdural hematoma, which means there's a collection of blood right there, just like on the left side. Epi means above, so that means it's above the dura mater, just like on the one in the middle. And intracerebral, intra means inside, and cerebral refers to the brain, which means that there is damage to the brain inside of it. So when you go to approach, remember BSI, scene safe, PPE. Always consider the possibility of a spinal injury, and remember that's when you're going to grab manual C-spine first. And then go through your ABCs. Remember, go through immediate life threats. That's where people are going to die. So when you go to talk to them, try to figure out what happened, but it's also going to help you gauge their mental status. Dressing and bandaging open wounds, if it's on the brain or on the head, I mean, obviously you're not going to put direct pressure, because if it is an open wound, open skull wound, then you want to put pressure on the brain. If every time you push down on that bandage, their arms jump, that's probably not good. So please stop. And remember, manage them for shock. Be prepared for vomiting, because you're probably going to have suction ready, especially if you've got them immobilized. They're not going to have the ability to sit up and just throw up like you could. When they start feeling it, they're kind of stuck, or they may be confused and not see it, and you don't want them to aspirate. Just monitor your vital signs every 5 minutes. Remember, that's a minimum. That doesn't mean sit behind them and just talk to them every 5 minutes. You're going to do a constant reassessment by talking to them, because that's when you're going to see if all of a sudden that they start becoming lethargic or confused. I guess if they start asking the same questions a little bit. And keep your pulse ox on. It's a constant thing. It monitors them, but it also shows your heart rate. If all of a sudden their heart rate starts dropping, or they start breathing erratically, anything like that, it's easy for you to look at. It's a constant assessment with a monitor vital signs every 5 minutes. It's just what they're saying. So this is when the pressure starts rising. So intracranial, remember, intra means inside, and the cranial, we got the cranium and the pressure that's in there. You have normal pressure. But remember that subdural hematoma? Let's talk about that one. So it's a closed space. Everything in there is closed. So when the blood is starting to collect, there's no place for it to go. So that hematoma, as that pressure's increasing, it's putting pressure on the other tissues in there. And it starts compressing the brain tissues. Then eventually, blood can't go to the other parts of the brain. It's abnormal electrical responses. Now, depending on the rate that it's bleeding, depends on how fast the symptoms are going to happen. So, and even at the bottom it says, takes time for symptoms to develop, depends on the rate of bleeding into the skull and location of the bleed. That also, with elderly people, is going to be different because as they age, their brain size decreases, which unfortunately leaves them more space inside their cranium. So they take a lot longer and more bleeding before they start becoming symptomatic. That's why you can have somebody that falls and then hours later, then they go to wake them up and they won't wake up because it took that long for them to know. As that intracranial pressure rises, what it starts doing is it starts doing something that's called herniation. It's where there's only so much space inside that place. So as it starts increasing in there, it's going to start pushing out the bottom of the foramen magnum. So you'll know when that starts happening because these people are going to be altered. They're not going to be sitting up talking to you normally, but you're going to start noticing the rise in the blood pressure and the slowing of the heart rate, which is really odd. But if you go on page 795, it'll break it down for you. And it really explains what Cushing's reflex is and why it's doing it. But in a nutshell, what it is there's too much CO2 in there, and because it's not perfusing enough. So carbon dioxide is being built up in there and causing swelling. And so it starts pushing it down through the bottom, and they call it herniation because it's herniating out through the bottom. And you'll also have dilated pupils in addition, or sluggish, but usually the typical thing is going to be the blood pressure is going to start rising and the heart rate's going to start dropping. But like I said, page 795 does a great, 4 paragraphs explaining more in depth, and that's an important one to know. Going back to that, let's go back to that. When you start noticing that this is happening and they're having herniation, now normally we wouldn't hyperventilate anybody. This is one of those times that we would. You would hyperventilate them to blow off excess carbon dioxide out of their system, so it'll decrease the amount to help reduce everything. So when you start going through everything, when you start seeing these signs of the vital signs changing, and then you might see them posturing and they're unresponsive, that's when you would hyperventilate them. That is the only time you would hyperventilate a patient. And remember, hyper means fast, faster than normal, and ventilation is the movement of air in and out. So you would be ventilating them at a higher rate than normal, and that's only enough till the symptoms subside, and then you would return back to their normal rate of ventilation. So here's your symptoms again. So Cheyenne-Stokes, there's some abnormal breathing patterns that you will see. And when you start looking at it, so Cheyenne-Stokes is a very distinct pattern of breathing. It's characterized by the quickening and deepening of respirations, and then they have a period of apnea. So they get really fast, deep breathing, and then they just stop for a little bit. It's very odd. Decordicate or decerebrate posturing. So decordicate, remember, is the posturing where they're going to be, they're more on their extremities and everything are drawn towards the core. And then you got your decerebrate where everything is kind of facing out. Maybe immediate or delayed in onset. So when you get up there and you immediately walk up to it, so think about it. When you walk up there, if they have a serious head injury, unfortunately there's not much you can do for it. Do you need to take them to a trauma center? If you have the indications and the mechanism that goes with that, then yes. The answer is yes. Don't take them to a community hospital with limited resources. You need to take them to one that's the best, most appropriate facility. Or even if they don't have a head injury, Does my patient's complaint and mechanism of injury indicate spinal stabilization? Is immobilization warranted? Yes, absolutely. Think about it. Think of that mechanism of injury. And then what is some potential complications? Because just as they're walking around doesn't mean that everything is completely fine. You still might need to be proactive. So let's say that screwdriver we talked about earlier was the foreign object was shoved in there. So the guy had some screws loose. The other guy decided to help him out with the screwdriver, stabbed him in the head. So remember, you don't want to remove any kind of impaled object like that, but you want to stabilize it, because remember, you don't want it moving around causing more injury. Now, let's say it's referring to a lengthy impaled object should be done with a tool that will not cause the object to move or vibrate when it's finally severed. So think of a piece of pipe or rebar. Somebody falls and a piece of rebar goes through part of their head. How are you going to get it out? Oh, well, I'll just get a saw, or I'll take the tools off the fire truck and I'll do the snips. Well, when those snips are happening, depending on which kind, it's going to cause it to manipulate and can cause it to move. And so that's a problem. Or vibration. If you're using a saw that's in the piece of metal is not stabilized correctly, those vibrations as it's catching and pulling the pieces of metal away is going to be shaking around inside this dude's head. So use thought about that. How would you stabilize it? So when you get to the injuries of the face and jaw, remember airway. Airway. If you do not have oxygen, or if you cannot breathe, then everything else is going to die. Now, possible position to allow drainage from the mouth, because it makes it a whole lot easier than you having to police with a suction unit, or even small amounts of secretions when they can't maintain their own airway. They can't swallow. So you just want to make sure you're keeping that where you can kind of roll them on the side if you need to. Now, you might have different parts of brain injuries that are caused by non-traumatic events. So hemorrhage, blood clot, stroke. So it's going to be the same, except there's no mechanism of injury, as far as no injury by an outside force, no trauma. Glasgow Coma Score. You will see this 100 times forever. It's going to be on every chart that you ever do. So you need to learn this. It may even be on the cards that I gave y'all. But this is a pretty standard thing. So what it is, and I've added a chart in there in a second, I'll show y'all. So what this is, it does a neurological assessment. It's very quick and easy once you learn it. But what it does is it has 3 categories, and it's eye-opening, verbal response, and motor response. We'll just skip straight to it. Remember, do not spend time just trying to calculate it. Do it on the way. They don't need you if they've got a head injury and they're severely injured and you're ventilating them. They don't need you to calculate that. They need to get to a hospital. You can do the rest on the way. CDC recommends that anything with basically a GCS of 14 or less be transported to a trauma center. So this is your Glasgow Coma Score. The highest score that you can get is 15. 15 if you're normal. And if you look at the bottom, no eye opening, no verbal response, and no motor response under each category is 1 point. So everybody gets at least 3. You get 3 points just for showing up. 15 if you're normal. But even one of those, like let's say verbal response, if I walk up and their eyes are open, they're looking at me, they're kind of moving around, they obey a command, hey man, can you sit down? He sits down, but they're really confused on what's going on. Then if you add that up, 4 plus 4 plus 6 is going to be 14. So it's pretty easy to do like that. So just, like I said, familiarize yourself with that. But the quickest ones is 3 if you're dead, So you get 3 points for showing up, 15 if you're normal, and 14 if you're confused. Anything other than that, I'll be honest, I have to look it up. Then we get to the neck. So remember, you got a lot of large arteries and veins close to the surface. Anything like that. So if I get shot, cut in the neck, anything like that, it's a big deal. There's that ambulance again. So think about it, like even the carotid arteries, where you feel that pulse, that carotid pulse. There's that. You got 2 carotid arteries. I mean, and think about all these large veins in there. Huge potential of problems. Because especially where are those arteries and things going? They're going to the brain and they're returning back to the body, to the heart. But the pressure in these large veins is a lot lower than atmospheric pressure. So you need to make sure that you start thinking about that. So that puts them at a high risk of air embolism because it can suck air. So the fact that the pressure is lower in the veins than in the atmosphere is what causes that possibility of air embolism being sucked in if it's been cut. Not completely, but it can suck it down in there. And then the treatment, obviously you need to stop the bleeding, prevent an air embolism. So how do I stop air from being sucked into that wound? Well, your fastest thing is going to be a gloved hand. Why is a glove important? Because it's occlusive. It means that air cannot pass through it. Because that's what it needs to happen, is I need to stop any air from being transferred through it. So if I use gauze, you can suck air through gauze. So gloved hand's fastest thing you can do, just like with an open chest wound. You can put a gloved hand on there while you're figuring it out. Do the rest. Then we're good. So remember, start doing your patient care. Make sure the airway's open. Gloved hand over the wound. Put your occlusive dressing. Do whatever you need to. Put the pressure to stop the bleeding. And then immobilize it. So assume possible cervical spine injury based upon the mechanism of injury. So remember, MOI means mechanism of injury. What kind of injury or what happened to cause them to be injured? So when you start thinking about it, if I walk up and I fell down 15 steps, yes, that is a possibility. That's a significant enough mechanism of injury that I could have caused some sort of neck problems. Because remember, my neck is very exposed. There's nothing that protects it. It can get flopped around either way. So compared to if I walk up and I stub my toe, the mechanism of injury is probably not going to be much unless I didn't fall. I just injured, isolated, localized injury on my toe. I don't need a seat collar. But remember, your spinal cord, that's how everything is related between the body and the brain, and you are at risk of the primary and secondary injuries. And we'll talk about secondary injuries later. So here's some more different mechanisms. So let's look at the guy on the top right, the impact in the windshield. So he just smashed his face. Remember, he wasn't wearing a seatbelt. We talked about this earlier in the year. So even though he just stopped, and whatever speed he was traveling, that moment he just now hit that windshield at that speed because the seatbelt didn't stop him. So remember all the different impacts that happen in a car wreck. So he's traveling, car hits tree at 55 miles an hour. He hits the inside of the car at 55 miles an hour. So there's that. So even just in that picture, you can tell that you're going to have head, neck, and face injuries that you're going to have to be prepared for. Also look at the diving. So diving is actually pretty common injury. That's why they don't want you to dive, because it overextends it. And it kind of overstretches it. Flexion and extension injuries. Now look at the woman at the bottom. So the reaction when the head goes back and forth, that's kind of like a whiplash. So because your head is whipped back and forth, it's an abnormal motion. If the headrest back there helps prevent that. So that's what you need to keep your headrest correctly, but it's usually pretty common with those injuries. moving forward. So you obviously remember mechanism of injury is because you need to pay attention. Just because they look fine, if the potential is there, you need to err on the side of caution. And you need to assess the physical condition. Just because you walk up and they say, yeah, I'm fine. Hey, let me talk to you. Just let me check you out. So there is things. So high risk, remember, falls greater than 1 meter, down more than 5 stairs. Remember, I fell down 15. So yeah, that's pretty big. Axial loading, compression. So that load was put directly towards the center. Diving injury, especially when you hit. And then you got high-speed motor vehicle crashes. Rollover, you're thrown every different way. Ejection, who knows what all is happening when you're thrown. So remember, your normal range that likes its comfort zone. So when you have any energy that makes it move a different way, you have an injury potential. Then remember, we're talking about whiplash. I remember that because that's when people don't have their head rest or something, or their head gets flipped like a whip. And you can't have certain medical conditions that can make it more likely to be hurt. Remember ATV accidents? Bicycle collisions are pretty common because there's no real protection in there. Like I said, vehicles involved, especially if they got hit with one. But there is other injuries, mechanisms that can cause spinal injuries. With that being said, one of the most common ones that I've seen that people don't think about is, unfortunately, like if somebody's got something wrapped around their neck or it's an attempted suicide and they step off of something, their weight of their body has now dropped it. So has now dropped and their head was held in place, and that can cause a stretching of it and can make a problem. So you need to make sure you immobilize those people. Don't just cut them down. You need to put them in a cervical collar. So remember pain and tenderness. Pain is obviously means that there's something wrong. There's some sort of injury. That's what tells the body that, hey, that's not normal. And tenderness is also, remember, hey, that's not normal. That's part of your trauma assessment. But hey, it hurts when I move my neck. Well, they shouldn't be moving their neck. Like I said, you need to do point tenderness when you're touching it, not, hey, can you do jumping jacks and see what happens? So your dermatones is part of your peripheral nervous system when you go through and how each one affects different parts of the body. There's a really good illustration in your book that I was looking at. So if you look at different parts of your dermatones, like let's say part of your thoracic, if you injure certain ones in your thoracic column, it actually causes abnormal sensations in your fingers, hands. There's different things like that. And that's where dermatones come in. And that's all explained on page 808. But you'll be able to know, kind of guess where the area is. Now, I know you're not a spinal surgeon. I get it. But it is kind of good to know and have like a general idea. Like, you're not going to be quizzed on which one does the left toe go to. No, but I mean, if somebody's saying, gosh, my fingers feel really funny on both, it's just weird. You know, this one side, it's like kind of like a pins and needles burning sensation. Feels like my fingers are asleep. Well, that's weird. So that can be actually an abnormal neurological symptom. Also, paralysis, obviously. Paralysis is a neurological thing because you have now lost motor control. Also, neurological function. If you start having pain, remember that means that there's something not right. If you start doing the midline spine, the tenderness, like, hey, it hurts when you start pressing. I'm not saying like press hard, but when you're running your fingers, hey, checking off if there's any step off or deformity, you make sure everything's in line. Or if they start having any kind of breathing problems, then you need to be paying attention for it. Priapism. Remember we talked about that. Everybody jokes about it. But it's actually a really bad thing. Like if you have somebody there and they have a priapism, that means that everything's dilated. They have some sort of neurological problem. It's not good. Same with loss of bowel or bladder control. That's not normal. Then obviously deformity. But let's talk about neurogenic shock. So neurogenic shock, remember in the past we talked about the different types of shock. So neurogenic is a specific type of shock. It's because part of the spinal cord for whatever reason. So usually when you go into shock, remember shock means hypoperfusion. Your body starts detecting it. It increases its heart rate. There's all different things. We just talked about all this. Increases heart rate because it's like, oh my goodness, my pressure's dropping. I need to speed up my cardiac output. So it increases the heart rate. Starts trying to constrict, trying to make it up for, because the body knows that it needs perfusion. I need that oxygen and nutrients. Absolutely. But remember when we were talking about the sensory nerves earlier in this presentation, how when those are damaged, that's the body talking, it's sensing the senses inside the body, the sensory nerves, such as blood pressure's dropping, there's injuries, things like that. It sends it back to the brain, and the brain is what tells them to do that, kind of like a compensatory mechanism. How do they compensate? Problem is the phone line's been cut, is about the easiest way to put it. So with that happening, so now the pressure and everything is dropping. My heart rate's not going to increase. So even though my blood pressure is dropping, my heart doesn't know that it needs to be doing anything. It kind of is in its own little world. So when you have these people, everything is dilated. The blood vessels are dilating because it's not being able to expand and contract, dilate and constrict to compensate for the pressures that are being needed. And the heart rate's just chilling, normal. So if you find somebody that's in trauma and they look and they're hypotensive, that's not good. They're profoundly hypotensive and their heart rate's not increasing. Possibility is because it's neurogenic shock. So if you got a pressure of 60/40 and a heart rate of 74, that's not normal. It could be in shock. Neurogenic shock. It's kind of like a high space shock because the volume's still there. It's just the containers have increased so much that there's no pressure, that it has dropped the pressure. So remember, when you get old, start losing decreased bone mass. So that puts them at a higher risk of spontaneous fractures, any kind of fall, anything like that. They can have significant injuries because of it. So when we get to patient care, remember, just like in those little sheets, first thing, C-spine. Do I need to consider C-spine? That's because you don't need to be checking something if they have a major neck injury and moving the neck around. You need to grab it real fast just to make sure and keep it in line, because you don't want to cause any kind of injuries. And then go through your ABCs. I grab C-spine, airway, breathing, circulation. Is the airway clear, patent? Yep. Okay, are they breathing? Yes. Are they breathing well? Is it adequate to maintain their system? Yes, they could be breathing 3 times a minute, and the answer is still yes, they're breathing, but it is not adequate to maintain that system. Well, circulation. Do they have a radial pulse? Are they peripherally perfusing? What's their skin look like? Are they pale and diaphoretic? Is there any kind of major bleeding that I need to stop real fast? And then after I've assessed the head and neck real fast, put that rigid cervical collar on. It's going to help hold them in place. And then you want to assess, remember, the pulse, motor, and sensory, and that's your neurovascular exam on all extremities. So remember, you want to find the correct, appropriate spinal immobilization. And then remember, after you apply everything, you want to reassess this, because if they weren't having any problems before I put them on this in this neck collar or try to immobilize them, and then now they can't feel their legs, we should probably readdress that because something happened. So spinal immobilization, we used to put everybody in spinal, and that was the most important thing. Everybody had to be put in a neck seat collar, on a backboard, don't move, everything. Now we've kind of backed off on as far as the backboard. Yes, it can be used, but the stretcher does just as good a job as restricting movement. But also, they can have secondary injuries. So secondary injuries after the initial injury, obviously, that is caused by other things such as hypoxia, which is lack of oxygen, shock, so inadequate perfusion, or low blood sugar. Because you remember, you need the blood, the nutrients, the oxygen, and the glucose to make everything work, for the cells to function. Now, if you're not ventilating, improper airway maintenance and ensuring adequate ventilation and oxygenation, then they can become hypoxic. Or if you let their blood pressure stay low for too long, that can go shock, because if they don't have enough pressure to perfuse the brain adequately, that can do an issue. Or if their blood sugar is too low for a long period of time, that can cause an injury. So we used to call it spinal immobilization. Now it's called spinal motion restriction. Like, we want to reduce it. We're not just like strapping them down to a board. So remember, spine is anatomically curved automatically. So that's the thing. They're not going to lay flat like that. So remember that. As soon as you first get there, you put your hands on either side of the head, properly sized collar, because it needs to actually work. And all you're doing is trying to restrict it. So you want to use another immobilization device. Remember, backboards, they are useful, but the stretcher does just fine. Once you get them on there, that's fine. Use a scoop stretcher, something like that, to move them. Like I said, a backboard, you can still do it. That was the true immobilization thing. The other things were just for movement. But once you lay them on there, if they're moving, if they're in a seat collar and not moving around, then it's still adequate. But who knows? Vacuum mattress, remember, would vacuum up around them. It just depends. So there's them applying a cervical collar, and you see that you have the guy behind them that is holding it because they're not blocking anything, and the guy on the side is adjusting that. And we're going to go back through that again on how to do that and how to use those multi-size things. So make sure you use the correct cervical collar, the size of it, because you don't want to try to shove a pediatric on a longer necked person, because it's not going to do anything. It's just like a necklace for them. If you do not have the right one, like especially with an infant or a child, use a rolled towel. Something you can roll it around and try to restrict them. You can roll it around, and kids are hard, especially with an infant. They don't really have a neck to fit around. It's hard to find correct stuff, but keeping towels, everybody's supposed to have blankets and towels on their truck. State guidelines, roll it up, nice roll, and adapt. Roll it around there and pad between where it is. You're restricting them. That's all you're doing. So you can have, if you got a low priority patient, it's somebody that's in a seat, like in a car or something like that, you can use a short board or vest mobilization device like KED that we're going to play with again. You have your high priority. Like I said, if you got to get them out, keep stabilization, try to keep everything in line with the neck, and then move them. Get them out. We got to go. You got your vest style extrication device, which, remember, KED, we'll look at it. Short spine board. It just looks like a half backboard. And we're going to look at one of those again too. Now, when you're doing everything, when you're securing everything, remember, everything else gets secured first with the torso and everything. The head is last. And you do not let go of it until it is completely secured to the thing. You do not release your manual stabilization with your hands until it is put on there, until it is secured to the device, if you're using one like that. Now, remember, we talked about before, you need to assess the back, shoulder, everything. Before you put them on something, you need to assess it. Especially before you're putting it on there, if it's placed against the patient, then you won't see it again. And then when you're putting that in there, you need to angle everything and just adjust it without moving anything around. And that's just going to take practice. The more you fumble with it, the more you'll become comfortable with it. Makes it a lot easier. And we're going to talk more about this KED in there. But the big thing is never place the chin cup or chin strap on the patient, like as it can prevent them from opening their mouth, especially if it's tight like that. If they have to vomit, they need to vomit. And remember, avoid tightening the first torso strap too tightly. Because also, if they go to take a deep breath, can you really take a good breath in and out? Can your chest expand? When you go take a deep breath like that, if you've got somebody that's tightened a belt really bad around it, like I said, some of them might have quick release stuffs. And do not pad between the collar and the board. Like I said, you just need to only pad everything because that pivot point will cause that to hyperextend. So remember, never use excessive padding. You want to keep everything in line. You don't want to cause it to move forward. And each manufacturer has their own instructions that you should know about them. So we got the cervical collar, and then there's the KED. You can see that being put around there, or I call it a KED. It's a, I don't know what to call it. You put them on a long backboard. Remember, you're going to roll them. Log rolling them. We're going to practice that some more. Pad the voids between the board and the head and torso. Like I said, I'll show you that, especially because remember, you kind of need to pad it because the spine is naturally curved. And then remember, secure the head last. If they're pregnant, you're going to tilt the board to the left because that fetus and everything will put pressure. If you got them laying flat, especially late-term pregnancy, it puts a lot of pressure on the veins and arteries behind it. So it blocks it off. Remember, I told y'all, veins and arteries are not hard, they're soft. So they're easily obstructed like that. And it reduces the amount of blood being returned to the heart and can cause them to become hypotensive. And so you just tilt them a little to the left. And then you would just strap. So remember with a kid, remember we talked about that they have a 6 years old or younger. This is just what they're saying. Each kid's going to be a little different. You're going to have to use your provider judgment. Padding beneath the shoulder blades, remember they got large heads, they got big heads. So when they lay down flat, their head automatically causes it to move forward and can cause an airway obstruction or cause trouble breathing. So when you're padding, you want to pad to keep everything in a nice neutral position. And remember, neutral, like your ears and everything should be in line and in a nice straight line. You can, immobilizing a child in child safety seat, like I said, it used to be recommended. It depends because it's only preferred, it's only rated really for that one impact. So if it's been a significant impact, then we can't really determine whether it is. So just use your judgment. So if you got like a rapid takedown, if you got somebody that's standing up, it's going to require 3 people. Remember, you're going to have your backboard, everything. The first thing you're doing is person says, hey, don't move, look at me, and walks to the front. Don't walk to the side because they're going to turn their head towards you naturally. And then you got 2 people that's going to put this behind them. Now, this isn't as common much, so you probably won't see one like this. But you can see where it does that, and they get everything centered behind the patient. And then you got 2 people, and it's really hard because it is scary for them. They've got still holding C-spine behind there, and then they've got underneath their arms, and they're just going to walk and move them down. This isn't very common anymore, but become familiar with it. As far as a helmet, leave it on. If it's long as it fits them, there's no movement, it's not going to block your airway or any kind of breathing, or if removing it would cause kind of further injury. Depending on the size of it too, because it might cause it to extend over, like flex the neck when they're laying back. But as long as it's fine and you can properly immobilize, everything's good, it's okay to leave it on. But also remember, it's not going to let you block it. Now, if you cannot see the airway and you can't assess it, then you kind of need to move it off. You need to get it removed. Or improperly fitted. That's going to be pretty common, especially in rural areas or stuff like that, because they're always going to be borrowing somebody's helmet if they're wearing one. Or you have small football teams, like for recreational places like the YMCA or things like that, or community centers that can't afford to buy ridiculous amounts of equipment for every single player that plays. So sometimes they have to kind of get one that's close to them, but it might not be the right one. Or if it interferes with immobilization. And then obviously cardiac arrest. Get that helmet off. Keep it in line, get it off, because we're going to have to ventilate. So we're going to go back over chapter review. So remember, 2 main divisions, nervous system, central and peripheral. So central is your main line in ones, the brain and spinal cord. Peripheral is everything that comes off. Remember, high index of suspicion. So not necessarily, but just kind of pay attention, stay alert, keep an open mind when you're thinking about it, whenever the mechanism of injury is capable. Now, before anything else, remember always, just like on that check sheet and stuff, it is to grab and consider inline stabilization or manual stabilization of the C-spine, because you don't want to be over there bandaging their toe and they had a broken neck and then they turn their head and cause some sort of long-lasting neurological injury at that point. Because that's why you want to consider it first, because it is so important of the life functions in that spinal cord or in that cervical spine. Remember, if somebody's altered, then you're going to want to automatically, it's a head injury. Treat them, do your best you can, and then document the mental status. Think your GCS, and they probably need to go, if they're altered, if they're confused. After a head injury that's like a GCS of 14, they need to go to trauma center. Remember, a traumatic injury is any injury that disrupts the function of the brain, anything from a slight concussion to severe hematoma. Remember, when you're securing, secure the torso to the backboard before the head. Head's last. Key components of the nervous system are the brain and the spinal cord. This is what regulates everything. Sensations, motor functions, everything. Heartbeat, breathing, anything like that. Now, the skull, vertebrae, and cerebral spinal fluid are what protect it. So you got your skull as the hard portion outside. Vertebrae is the bones in your skeleton, in your spine. And then the nice cushiony fluid is the CSF. It all kind of protects everything. Remember, closed head injury means it is closed because the skull was not broken. Now, Just because the scalp's been cut doesn't make it an open head injury. It's still a closed head injury because the skull was not perforated or is still structurally intact. But that closed container, remember, very little room, and once the bleeding starts putting a lot of pressure, increased intracranial pressure. And then you've got neck wounds, high risk of massive bleeding and air entry. Yeah, that's when we can cause the emboli. It's because the venous pressure is lower, inside the vein is lower than the atmospheric pressure. It can cause air embolism. So remember, occlusive dressing. Also, back on that, one thing I didn't really notice that was mentioned in CSF is sometimes when you have a skull fracture, remember that you could check the ears. We're looking for any kind of CSF. We just note it. That means that there is cerebral spinal fluid that is coming out down through the ear canal. Remember, that's when we check and verify that, because we can't do anything about it, but it is important to note it. The spine is injured most often by compression or excessive flexion, by extension or rotation from falls. Any of these injuries can interrupt nervous system control of the body functions. If anything, that can either compress it to the point of like an axial load, or if it causes it to bend and stretch any way that it's not supposed to, it can cause an injury. Remember, 33 spinal bones in the vertebrae. So think about it, 7, 12, 5, 5, 4. Remember which ones are where and what attaches to them. Spinal immobilization, we're going to practice that because it is important. So when you start thinking about something, well, do they have a mechanism of injury that would indicate the need for spinal immobilization? It's kind of hard to say. You're going to have to judge it. I mean, if somebody falls off a house, the answer is yes. What about a ground level fall? Personally, I have ran many times where I've had elderly patients that have fallen and ended up with a head injury. Ground level fall, standing position, fell, ended up with a head injury. I've had them with broken necks, different parts of bones, just because they've decreased bone mass and they're more prone to injury. So err on the side of caution. And if you do have the potential for this injury, then you need to take them to a trauma center. So, all right, so you got a guy with a head injury. He's altered. So, altered mental status, got significant mechanism of injury. Partner says that he thinks you should hyperventilate. When do you hyperventilate? Remember, let's think back to that. Hyperventilating is only to blow off the excess carbon dioxide because brain is herniating and they're having the Cushing's reflex. So what are these signs and symptoms? So they're going to be altered, possibly abnormal breathing pattern, high blood pressure, low heart rate. And so yes, exactly like I just said, high blood pressure and a low heart rate. And remember, it's Cushing's reflex. That's when you would hyperventilate. It might be posturing, decerebate, it's body positioning, decerebate, decorticate. Pay attention. All right, that's it.